Good afternoon, folks. This afternoon's topic A, workforce shortage is directly degrading dementia care. Okay, so we're going to discuss that for A. Please join me for the presentation I made for you. Here we go. The workforce shortage is directly degrading dementia care, hollowing out the very supports that allow people with cognitive impairment to live safely with dignity and with some measure of stability across every data set. Every state reports, every frontline account. The pattern is the same. Too few specialists, too few direct care workers, too few trained hands at the bedside. And demand is rising faster than the system can absorb. Dementia care is becoming more fragile, more fragmented, and more dependent on exhausted families. Core impacts. Dementia care is becoming less accessible, less consistent, and more dangerous because the U.S. lacks both the specialists and the direct care workforce required to deliver safe, person-centered care. The shortage is not an inconvenience. It's a structural failure that reshapes the lived experience of millions of older adults. How shortages affect dementia care. Severe shortages of dementia care specialists. The U.S. has only about 7,000 geriatricians, a fraction of what's needed for an aging population of 56 million adults 65 plus. Give me 1 second, folks. Neurology wait times routinely stretch 6 to 12 months, especially for memory clinics. Rural communities, nearly 70% have no dementia specialist at all. Impact. People wait months for diagnosis, lose access to early stage interventions, and rely on general lists who often lack training in behavioral symptoms, polypharmacy, and caregiver coaching. Dementia becomes a diagnose and disappear condition. Direct care workforce collapse. Direct care workers, CNAs, home health aides, personal care aides provide 80% of hands-on dementia care. Yet shortages are accelerating due to low wages, often 13 to $17 per hour, high injury rates, burnout, immigration restrictions that shrink a workforce heavily reliant on foreign born workers, impact, missed baths, missed meals, missed medications, rushed care that escalates aggression, agitation, fewer staff who know residents' histories, triggers, and calming routines. Loss of relational community, which is the foundation of dementia stability. When staffing thins, the first thing to disappear is time. The one thing in ingredient dementia care does not function without. 3. Higher caregiver burden on families. With paid care harder to find, families absorb more responsibility. 63 million Americans already provide unpaid care. Dementia caregivers provide twice as many hours as caregivers for other conditions. Many reduce work hours or leave the workforce entirely. Impact: burnout, depression, financial strain, and earlier crisis placements. Families become the de facto long-term care system, often without training or respite. Rising safety risks and poor clinical outcomes. Short staffing in home care, assisted living, and nursing homes leads to more falls and fractures, increased wandering, and elopement. Medication errors occur. Larger response times happen. More behavioral escalations. Higher hospitalization rates. Hospitals report sharp increases in dementia-related complications, especially delirium, because frontline clinicians lack specialist support and adequate staffing to manage cognitive impairment. 5. Reduced access to home and community-based services, HCBS. HCBS programs, adult day, home health, personal care, respite, are the services that keep people with dementia at home. But workforce shortages mean longer wait lists, limited hours, inability to staff rural and low income areas, agencies declining high acute acuity dementia care cases. Impact: people lose the option to age in place and enter institutions earlier than medically necessary. System level instability. The U.S. is experiencing a critical shortage of workers needed to provide geriatric and disability care. Meanwhile, dementia prevalence is projected to rise from 7 million in 2025 to 14 million by 2060. Impact: a widening gap between need and capacity, with no current trajectory toward equilibrium. The system is drifting toward a model where dementia care is rationed by geography, income, and family availability. What this means for dementia care. The evidence points to a structural crisis, too few specialists, delayed diagnosis, inadequate management, too few direct care workers, inconsistent, unsafe daily care. Too much burden on families, burnout, and crisis transitions. Growing demand, a system unable to keep pace. Dementia care is becoming more fragmented, more dependent on unpaid labor, and more vulnerable to policy shocks. Immigration wages, immigration, wage, wage, wages reimbursement. Without intervention, the gap between what people need and what the system can provide will widen dramatically. Okay, guys, here's the second half of A. Um, Stabilizing the dementia care workforce, prepared for senior health systems and state policy leadership in Pennsylvania. The, the dementia care workforce is entering a period of structural instability driven by accelerating demand, severe shortages of direct care workers, limited specialist capacity, and chronic underinvestment in long term care. Without coordinated state level action, Pennsylvania will face rising hospital congestion, earlier institutionalization, widening inequities, and escalating Medicaid expenditures. A, a, a sustainable dementia care dementia workforce requires a multi-level strategy that strengthens supply, elevates capacity or competency, stabilizes wages, expands home and community-based services, and supports family caregivers who provide the majority of dementia care. The workforce challenge, a system at the breaking point, demand outpacing supply. Pennsylvania's population, 65 plus, will grow by 30% by 2035, with dementia prevalence rising proportionally. Dementia care requires intensive relational time dependent support, yet the state lacks the workforce to meet this complexity. Critical shortages across the continuum. Direct care workers vacancy rates exceed 20 to 25% in many LTC settings. Memory clinics report months month, months long wait times for diagnostics diagnosis and management. Rural uh, rural counties face nearly zero access to dementia specialists. Consequences of the system: increased emergency department boarding, unavoidable hospitalizations, delayed discharges due to lack of post acute capacity, high rates, higher rates of behavioral crises, and caregiver burnout. Earlier, costlier institutionalization. Why dementia care is uniquely vulnerable. Hard complexity, low margin. Dementia care requires behavioral health integration, skilled communication, cons- consistent staffing, trauma informed, person centered approaches. Yet the workforce delivering this care, CNAs, home health aides, personal care aides, remains among the lowest paid and least supported in the healthcare system. Dependence on immigrant labor. 1 in 3 direct care workers is foreign born. Immigration restrictions and deportations disproportionately destabilize dementia care, especially in rural and underserved regions. State strategies to stabilize the dementia workforce. Establish statewide dementia competency standards. Implement mandatory dementia specific training for all LTC and HCBS workers. Impact: improve safety, reduce behavioral escalations, higher retention, create career ladders, and paid apprenticeships. Develop CNA dementia specialists. Lead aid LPN pathways. Impact: stronger recruitment, reduced turnover, internal pipeline growth, reform Medicaid rates with wage pass-throughs, The rate increases to direct care work to direct care wage wage floors and transparency requirements. Impact stabilizes workforce supply and reduces current expand immigrant workforce pathways, accelerate accreditation for internationally trained nurses and aides, impact rapid workforce expansion in high need areas, strengthen HCBS infrastructure, increase adult day capacity, dementia capable home health teams, and respite. Impact supports aging in place, reduces hospital utilization, support family caregivers as core workforce, provide stipends, training, respite, and navigation services. Impact reduces crisis, transitions, and delays institutionalization. Implementation priorities for Pennsylvania. Launch a dementia care launch a dementia workforce innovation fund. Send grants for training, apprenticeships, and dementia capable care models. Adopt a statewide dementia capacity framework, competency framework, align training across nursing homes, assisted living, home health, and adult day services. Reimburse HCBS and LTC rates. Ensure reimbursement. Support competitive wages and retention. Build a dementia navigator network. Deploy navigators through health systems, area agency on aging offices, and community partners. Expand geriatric and dementia specialty training. Incentivize clinicians through loan repayment, fellowships, and rural rotations. Strategic relational rational for action now. Economic. Stabilizing the workforce reduces Medicaid spending by preventing avoidable hospitalizations and delaying nursing home entry. Operational. Hospitals cannot function efficiently when dementia patients cannot be discharged. Equity. Rural, low income, and minority communities face the steepest workforce shortages. Political. Bipartisan support exists for aging in place, caregiver support, and workforce development. Executive recommendations. Pennsylvania should adopt a comprehensive multi level dementia workforce strategy that integrates competency standards, wage stabilization, career ladders, immigrant workforce pathways, home community-based services expansion, family caregiver supports. Okay, guys, that is your A for this afternoon. I will be back on later with B. For now, Gator Wellness. Take care, folks.